Hello dear students, I am Jenei and I will introduce you the follicular hyperplasia slide. First we have to talk a few words about the differential diagnosis of lymph node enlargement. In general, lymph nodes greater than 1 centimeter are considered to be abnormal. However, children may respond for an infection with a significant enlargement. Lymph node enlargement can be observed in a single area or can affect multiple lymph node regions. Therefore, we can talk about localized or generalized lymphadenopathy. And this is the differential diagnosis of lymph node enlargement. Acute and chronic lymphadenitis due to microbial, viral or bacterial infections or non-microbial causes such as medications or autoimmune disorders. Also, primary and secondary tumors of the lymph node can cause enlargement. Lymph node enlargement is suspicious for malignancy if it's painless. Pain is usually the result of an inflammatory process or suppuration, but pain may also result from a hemorrhage into a necrotic center of a malignant tumor, so it's not the most reliable symptom. If the lymph node is firm and fixed, stony hard nodes are typically a sign of cancer, usually metastatic one. Very firm, rubbery nodes suggest lymphoma. Softer nodes are the result of infection or inflammatory conditions. Supraclavicular lymphadenopathy has the highest risk of malignancy, estimated 90% in patients older than 40 years. If the lymphadenopathy is persistent or progressive or just simply generalized, it's all suspicious for malignant tumor. If there is coexistent hepatosplenomegaly and or peripheral blood abnormalities, or you can notice the signs of systemic illness and you have no data of infection, medicines, autoimmune disorders, etc., then you have to exclude the possibility of malignancy. We can group reactive lymphadenopathies into three major categories according to their predominant architectural histological pattern. These are follicular hyperplasia, paracortical or interfollicular hyperplasia, and sinus histiocytosis. Follicular hyperplasia is a B-cell reaction in response to bacterial infections, HIV infection, or rheumatoid arthritis. Paracortical or interfollicular hyperplasia is a T-cell reaction representing immunologic reaction to drugs, viral infection, and after vaccination we can see this type of hyperplasia. Sinus histiocytosis is a macrophage reaction or response that we will usually see in chronic infections or in a lymph node draining the lymph from an area involved by a solid tumor. Today we're gonna focus on follicular hyperplasia, and I ask you to please open the slide. Here you can see a lymph node surrounded by fat tissue. Here you can see the capsule of the lymph node. Here you can see the cortex of the lymph node, and this is the medulla. Now here you can see the subcapsular, and in the middle the medullary sinuses. The medullary sinuses in this actual case are a little bit dilated. Now in the cortex you can see numerous and usually enlarged follicles which are extending into the medulla as well, while usually they should be restricted to the cortical areas. Around these follicles you can see a pale area called marginal zone, then a more darker area composed of small lymphoid cells called mantle zone, and in the middle you can see the germinal centers. In the germinal centers, we can see at least two very characteristic cell types. One of them are these small lymphoid cells with irregular nuclei. These are the centrocytes. Next to them, we can see some bigger cells with prominent, often multiple nucleoli called centroblasts. The nucleoli of the centroblasts are often attached to the nuclear membrane. Now, next to these cells, we can see some apoptotic cells eaten by so-called tingible body macrophages. So this is a follicle, and if we scan through this slide, we can also see some interesting areas with some funny looking cells I hope you are familiar with. These are multinucleated foreign body type giant cells, in which we can see some kind of foreign body in their cytoplasm. You may wonder what are they doing here, and I'm not 100% sure, but I would say that this is a lymph node which was probably removed from a neighborhood of a foreign body granuloma, and this is a lymph node which is draining the lymph from that area, and that's how these giant cells could enter to, or could travel to the lymph node. So it was follicular hyperplasia, and thank you very much for your attention.